Okay, so we're going to start the morning off with ectopic pregnancy, and this is on page 351 in the old manual. This is actually a little different from the rest of the chapters because if you kind of flip through it, you'll see that there's only 8 papers. So maybe it's a good one to start off with in the morning because it's not so heavy and dense with 40-something abstracts. So ectopic pregnancy has really changed a lot for most of us. Making the diagnosis has really changed with our increased utilization of ultrasound, increased availability of ultrasound. Many of us are even doing our own ultrasounds. And almost all obstetricians are doing ultrasounds in their offices. They're doing them earlier, more frequently, picking up a lot of these ectopic pregnancies in the office themselves, managing them as outpatients. So the management's really changed, also with the introduction of methotrexate and medical management as well. Some people think that the incidence has kind of gone down because we're not seeing maybe as many of them, but that has to do with, again, how obstetricians are managing them. But actually, it's probably gone up in some studies that you look at, the incidence of ectopic because of the increased rate of infertility treatments and women trying to get pregnant as they get older. And it's still the leading cause of maternal mortality in first trimester pregnancies. In the chapter in the introduction, it lists that the incidence is about 1 in 50, and that's probably true for all pregnancies. But if you really think about the pregnancies that present to the emergency department with a complaint with abdominal pain or vaginal bleeding, it's much higher than 1 in 50 for us, what we really see. In fact, it's probably as high maybe as 1 in 10, so that if you pictured 10 different women presenting in first trimester with abdominal pain or vaginal bleeding, of those, if you had 10 of those, probably 1 would be an ectopic. That's on the high side, but probably about 1. Of those 10, 6 would be normal pregnancies, would end up being normal pregnancies, and then the other 3 would be non-viable, spontaneous abortion type patients. So it can be pretty frequent in the patients that we see. When the ultrasound is diagnostic, certainly fine. We know what to do with indefinite uterine pregnancy and with a ruptured ectopic. Sick ones are easy, but it's when the ultrasound is indeterminate or your beta is on the low side or somewhere in that kind of gray zone is when it gets a little bit trickier, and that's really what we're going to focus on today is the tricky ones, not the sick ones. And we're going to talk a little bit about methotrexate and how that's used and who should get it and that too. When the ultrasound is indeterminate, we have to rely on the serum hormone testing, whether it's serial beta-HCGs or serum progesterone, which is what we're going to talk about a little bit here as well. Certainly an ectopic exam is very unreliable. We probably all know that. 30% of ectopics have no bleeding at all. Only 10% maybe will have any kind of palpable adnexal mass. 10% are going to have completely normal pelvic exams. So there's really no combination of exam findings that you can say either rules in or rules out ectopic pregnancy. Not a really reliable part of our evaluation. Something we have to do, but not that reliable. So the first question that's posed in the chapter is it clear that a single progesterone measurement helps in the diagnosis of ectopic pregnancy? How many of you use progesterone at all in your evaluation of ectopics? Anybody? Not frequent. Actually probably a lot of labs do it. You don't know that they do it. They don't do it on a stat basis, so maybe it doesn't help. But let's just talk about it. Some of these studies actually illustrate some interesting statistical things too. So it's a good thing to know about, and it's the one new thing in the last 15 years in ectopic, besides the increased utilization of ultrasound, that's come out to be maybe helpful in the screening for ectopic pregnancy, because it's a single measurement as opposed to betas, which are serial measurements. And there is probably some utility there, but a lot of gray area too. So progesterone is secreted by the corpus luteum, and in normal viable pregnancies, it will just go up and up and up and up. But in abnormal pregnancies, both ectopics and ones that are going to go on to be spontaneous abortions, it stays low or doesn't really go up much at all. So this test has been proposed as a good screening test for abnormal pregnancies. Whether it's an ectopic or a non-viable pregnancy is hard to differentiate based on this test, but certainly we'll find in these studies that viable pregnancies tend to have higher progesterone levels, and so therefore it may have some utility because it's one test, not a serial test. So paper number 1 was probably one of the first papers to look at this test. It's called the ED Diagnosis of Ectopic Pregnancy. It was published in the Annals. It's from the University of Tennessee, where a lot of these papers come from. And they compared the value of the history and physical with screening progesterone levels in almost 2,000 women with a positive pregnancy test. In their group of patients, ectopic was ultimately diagnosed at about 8%. You'll see that over and over in these studies. Usually the incidence in these studies is around 7-8%. but the diagnosis was made on the first visit in only half of the patients, so they missed a lot the first time around. This was back again in 1990, so not all these women got ultrasounds. We're just talking about exam, looking at the beta, making a decision, and they sent serum progesterones on all of these patients that they were looking at, but they didn't get that back on a stat basis. It was something that came back later, and they looked at what the outcomes of these pregnancies were, whether they were ectopic, non-viable, viable pregnancies, and then what the progesterone level was. One of the points they make in this paper was that these women had very tricky exams, like we started out saying. Many had no pain, very few had any cervical motion tenderness, only 10% had any adnexal tenderness at all, and no patient had any adnexal mass in their whole series. And their point was that the patients with an unruptured ectopic can look just like an intrauterine pregnancy. You can't tell the difference on exam. They could find nothing looking at all the exam variables, going back, reviewing all the charts that would differentiate the two things. All of the 60 patients in their series who had a ruptured ectopic, they all had pelvic pain. So that's one thing that we can say from this study was that if it's ruptured, they're going to have some pain. In this study, they all had some element of pelvic pain. In the patients who had this positive pregnancy test, they sent the serum progesterone, and they had 161 patients that were ultimately diagnosed with ectopic, and they claimed that the serum progesterone caught all but one, 99%, of the ectopic pregnancies in their series. And they used a cutoff of 25, and we'll see as these papers go on that the cutoff of where you pick your cutoff to be is really important, depending on whether you want to miss a few or you want to catch them all. You know, it kind of depends. In this series, the cutoff of 25 caught almost all of them. But the problem with the cutoff of 25, again, remember that abnormal pregnancies have the low progesterone and the viable pregnancies will be high. They also had, obviously, below the level of 25, there were a lot of ones that went on to be viable pregnancies that also had low values. So there were a lot of false positives. So your sensitivity was very high. You didn't miss very many ectopics, but you also caught a lot of normal pregnancies, so the specificity was very low. But they suggested this could be a pretty good screening test if you were to test the serum progesterone and it was below 25. Maybe this is a way you would know that it might be an abnormal pregnancy, because the fact of the matter was all of the viable pregnancies had levels above 25. Some had below, but all of them had above 25, and not many of the abnormal pregnancies had levels above 25. So this was the first paper that suggested this, and then we kind of keep going. Number 2 is the same authors looking again at the serum progesterone level and ectopics, and in this study they looked at just over 1,000 patients that were being evaluated for a rule-out ectopic, and for 600 over those 1,000, ultrasound was all they needed, so those they weren't really looking at. They were looking at the 400 who needed something more than just an ultrasound. And they did a serum progesterone and they did serial HCGs in this patient population and tried to compare the two and make some statements about which one's more reliable, which one should you use. And they looked at 3 different cutoffs. Now they're starting to expand their scope and look at different cutoffs for the serum progesterone. What if we look at 10? What if we look at 15? What if we look at 25? Can we make some statements about whether these cutoffs would make a difference? And they compared this to the serial beta HCGs in these patients, where an increase of less than 66%, which is kind of the standard number in 48 hours, was considered abnormal. Of those 400 patients that they were looking at that needed something more than an ultrasound, almost 60% of those ended up with an abnormal pregnancy, and 38 had an unruptured ectopic. So they determined that the sensitivity of that cutoff of 25 for identifying an abnormal pregnancy was 97%, very good, didn't miss very many, but again, the specificity was very low, 30%. They had a lot of viable pregnancies that fell into that lower category, and so ruling them out was very difficult. They had a lot of false positives, lots of patients who had low serum progesterones who actually didn't have an abnormal pregnancy, who went on to have viable pregnancies. And so they tried to play around with the numbers, lower the cutoff, see if you can make the numbers look better. Maybe we can get those numbers looking a little bit better. But as you lower the cutoff to 10, the specificity improved. You didn't have as many normal viable pregnancies that had low numbers, but you started missing some of the abnormal pregnancies that had slightly higher numbers. And so the conclusion that they made here was that a level of at least 25 reflected a viable pregnancy 97% of the time, while very, very low levels, less than 5%, you could probably say that's a non-viable pregnancy. But anything in the middle there, you'd probably need something more. Serial betas, something else. You couldn't really say between 5 and 25 which reliably, whether it was a non-viable pregnancy or a viable pregnancy. So paper number three starts looking at this again. Serum progesterone as a screen for ectopic, exchanging specificity and sensitivity to optimize the test performance. Just looking at playing with the numbers again and trying to get those numbers to look better. Can we get a high sensitivity, not miss any, but also not have a lot of false positives, have a high specificity? And the difference here is that as emergency physicians, we want as high a sensitivity as possible when it comes to ectopic. We'd like to really not miss any. We don't want to have any false negatives. But for the OBGYNs, they don't want a lot of false positives. They have to deal with those. So they would like to have a number that's more specific. So the authors of these papers are kind of writing their papers for two different audiences that have two different goals in mind. And so they try to play with the numbers to get their test to look very good. In this paper, basically, again, they stated that increasing progesterone levels are associated with an increased chance of having a viable pregnancy, and the converse is true as it's lower, but they couldn't pick a number that was perfect. No matter where they moved the cutoff, the numbers were never 100% and 100%. They were still not perfect. Number four, serum progesterone and transvaginal ultrasound by emergency physicians in the evaluation of ectopic pregnancy. And this was in 1998 from the Medical College of Wisconsin. And it's a small study, prospective study of 68 stable women with positive pregnancy tests and symptoms of some kind of abnormal pregnancy, or they had a risk factor for ectopic pregnancy. And on their ultrasound, they had no definite intrauterine pregnancy or an ectopic pregnancy, so indeterminate ultrasound, which is just the population that we're interested in, and looked at their serum progesterone levels. In their group, just over a third ended up with ectopic pregnancy. Half of them went on to have spontaneous abortions, and the remaining 16% had viable pregnancies, intrauterine pregnancies. The 16% that had viable pregnancies, again, had significantly higher levels of serum progesterone, but they found that the serum progesterone really couldn't help you determine between the ones that had an ectopic and those who went on to have a spontaneous abortion, that you couldn't tell between the non-normal pregnancies, the abnormal pregnancies, which one was which. And in their study, the cutoff that was optimal, they thought, in helping determine these differences between a normal pregnancy and abnormal was 11. So they picked a new number. They went a little bit lower. 11 was the best in theirs. And it's, even with that cutoff of 11, they still missed 4 out of their 25 ectopic pregnancies and 4 out of the 32 that went on to spontaneous abortion. So even the abnormal pregnancies, that still wasn't a perfect number, 11, but they felt that was the optimal one they could find in their study. Paper number 5 is another paper by a guy named Dart, which is the ability of a single serum progesterone to identify abnormal pregnancies in patients with the beta less than 1,000. And this is an important number because this brings us to the concept of the discriminatory zone, which is at what level of a beta HCG in a normal pregnancy would you expect that the transvaginal ultrasound should definitely be positive? And that number is usually around 1,500 to 2,000. Around that number in a normal pregnancy, you should definitely be seeing something on your ultrasound. And so betas at about 1,000 are where you start getting these indeterminate ultrasounds, which is why this number was chosen. Just out of interest's sake, if you are talking about the discriminatory zone for a transabdominal ultrasound, at what level of beta for a normal pregnancy should you start seeing something on your abdominal ultrasound? It's about 6,500. And that's the discriminatory zone for that test. So in this study, it was a prospective study of 88 women with abdominal pain or vaginal bleeding and a positive beta HCG with a level below 1,000. And in these patients, a normal viable intrauterine pregnancy was diagnosed in 14%, which is 12 patients, so a small group of people. And the remaining 76 patients had abnormal pregnancies, whether it was ectopic or a non-viable pregnancy. 76 had abnormal pregnancies. 9 of those had ectopics. Their cutoff, at a cutoff of 5, very low progesterone level, their sensitivity was 94%. They picked up 71 out of 76 of those abnormal pregnancies. And 5 out of those 76 abnormal pregnancies had levels above 5, and one of those was an ectopic. So even looking at that very, very low cutoff, it's not perfect. You're still going to miss 1 or 2 there. The specificity of a level above 5 was 100%, so no normal pregnancy had a level that was as low as 5. And the fact is that as normal pregnancies progress in terms of this progesterone test, just like you would expect, they start out at a low level and they go up. So if you're talking about a very early normal pregnancy, they're going to have low serum progesterone levels, which is why you get this gray zone. Now let's just cut to number 7. This is the last paper we'll look at on this topic, and it's called Serum Progesterone Testing to Predict Ectopic Pregnancy in Symptomatic First Trimester Patients. And it's a paper by a guy named Buckley at the Naval Medical Center in San Diego. This is one of the larger studies on this topic. And again, they're trying to determine what the optimal cutoff was for serum progesterone. And they looked at a derivation set of 399 women with a first trimester complaint of vaginal bleeding and or abdominal pain. And then they picked a number, and then they validated it in 317 more patients with the same presentation. So a pretty big study. And the ectopic rate in their study was 7%. So again, kind of a recurring theme in all of our papers, around 7-8% rate. In this study, the cutoff that they picked was 22. This is the cutoff for them that ended up being 100% sensitive and picked up all of the 30 ectopic pregnancies in their derivation set. And the same number, 22, in their validation set picked up all of the ectopics in the second set, 22 patients. And so they picked that 22 as the cutoff. And what this should tell you with these different numbers also is that there's some variability also from assay to assay or lab to lab, that there's no standard. So one thing that you have to learn from this is that if you choose to use this test or you ever start looking at it, you have to know what your lab number is and how this starts working with your institution. But in this group, it was 22. They also found, though, that the specificity was very low. There were several viable pregnancies that had levels below 22, mostly very early pregnancies. But in their study, none of the ectopic pregnancies had a level below 22. Above 22. They all had levels below. So certainly we can take away from this that as a single test, it has probably some utility, limited, and you have to know what it is in your institution, but that ectopic and abnormal pregnancies have these low levels of progesterone while viable pregnancies have higher levels. Where exactly the line you can draw is impossible to say, I think. Levels above 25, very high levels, are pretty safe to say it's a viable, it is a normal pregnancy, viable pregnancy. And below that, we can't really tease out which ones are ectopic, which ones are going to go on to spontaneous abortion, but that abnormal pregnancies have low levels of progesterone. Now, paper number 8 is kind of an interesting paper. This is called Diagnosing Ectopic Pregnancy, Decision Analysis, Comparing 6 Different Strategies. And we've all seen these very complicated algorithms that walk us through, okay, you get this, and then you get the level, and then I'm going to get the ultrasound, and if it shows this, very complicated algorithms. They look at 6 of these published different algorithms and try to pick out what are the better elements of these algorithms, which ones are really the best. And it's a paper written by some OBGYNs from University of Pennsylvania. And these different algorithms that they looked at have combinations of transvaginal ultrasound, serum progesterone, serial beta-HCG, and DNC as the ultimate diagnostic strategy. And they took a hypothetical cohort of 10,000 women presenting to an emergency department with complaints that relate to abnormal pregnancy, abdominal pain, or vaginal bleeding, and calculated how many surgeries you'd have to do, what your missed ectopic rate would be with these different algorithms, time to diagnosis, what the charges would be, to try to, again, devise what the optimal strategy is. And they came up with the fact that performance of transvaginal ultrasound followed by the measurement of your beta-HCG in women with a non-diagnostic ultrasound is really the best, that these ultrasounds are really the best screening test. It's the best thing that you can do. And after that, then really the serial beta is the next best test. If you use this approach, you would theoretically identify all your ectopics with a mean time to diagnosis of 1.5 days, meaning that some are going to have a delayed diagnosis because you have to rely on the serial measurement of the beta-HCG. But that the progesterone test, what they kind of conclude, was not so great, but they agreed with the fact that if you have a level over 25, it's pretty indicative of a viable pregnancy. And it's useful in that way. It's almost never an ectopic if it's a high level. But beyond that, not such a great diagnostic strategy, in their opinion, with this hypothetical cohort of people. So now we get on to just a few reminders about how we use beta-HCG, some little tips about ultrasound and the facts about that, and some of the gray areas that come up with both of these tests that we end up relying on so often. HCG is first detectable in the blood about 7 to 8 days after ovulation, but most of your tests will be positive by 10 to 11 days, so pretty early after conception. And it doubles every 2 to 3 days in early pregnancy, and this is especially true for normal pregnancies, okay? So they all do that. However, when it comes to ectopics, do they rise, do they fall, what happens? Well, about 60% of the levels, so most of them will be falling if you take 2 measurements 2 to 3 days apart. But about a third of them will actually rise. They'll abnormally rise, but they will rise. And 1 out of 20 will actually rise normally. So ectopics produce HCG abnormally, but every once in a while you'll get one that actually will rise normally, that you'll catch it at a point where it hasn't become abnormal yet. So there are some gray areas there, not perfect. HCG levels peak at about 8 to 10 weeks, and then they start to fall. But for any given time in pregnancy, there's a huge variation of what a normal beta HCG is. So you can't really say that at this point it should be this, and this point it should be this. There's really a lot of variation there. So it's a difficult test to interpret in that way. Ectopics, are those that will go on to be spontaneous abortions, tend to have lower levels initially because of this abnormal production of HCG, but they can also have normal levels initially. So you just can't say. If a woman has been getting HCG injections as part of an infertility treatment, it's going to screw up your interpretation of a beta HCG because the half-life is long and it takes up to 2 weeks to really clear that out of the serum. So you have to ask about that if you have somebody who's been undergoing infertility treatments. About 45% of ectopics have betas less than 1,000, but the rest of them can have levels anywhere from 1,000 to 10,000. So that's why a single level is really of no utility. The best thing that we can do is look at it serially to see if it's rising, since the majority of them don't rise normally. Now, what kind of clues can you get from ultrasound? We just talked about the discriminatory zone, that by the time a normal pregnancy reaches a beta of about 1,500 to 2,000, you should see a uterine pregnancy if it's a normal pregnancy on transvaginal ultrasound. And the number goes up to 6,500 with a transabdominal ultrasound. Now, this correlates the transvaginal, that 1,500 number correlates to about 5.5 to 6 weeks of pregnancy. That's about 2 weeks after the first missed period. And at this point, again, they should all be seen. If you don't see something in the uterus, it's a pretty bad prognostic sign. So transvaginal ultrasound, you can see pregnancy about a week earlier by transvaginal than by transabdominal ultrasound. When it comes to diagnosing ectopic pregnancies on transvaginal ultrasound, what you're looking for is an empty uterus and some kind of adnexal mass, and maybe some free fluid. But really, the diagnosis of ectopic is only for sure on an ultrasound if you see a fetal heartbeat outside of the uterus, or the mass looks definitive to the ultrasonographer. Often, sometimes because of the corpus luteum and some different changes in the ovary, depending on where the ectopic is, it can be a little confusing. You see sort of this heterogeneous mass, it's off to the side, but sometimes it's a little confusing whether that's an adnexal issue or it's an ectopic. So that's why sometimes these reads come back as indeterminate. They're not sure exactly what's going on. By ultrasound, 10 to 20% of ectopics will have what's called a pseudosac on ultrasound, which is something in the uterus that starts to look kind of like a gestational sac, but it's not looking like that at all. It's sort of like a single ring versus a double ring, which is a gestational sac. So this can happen. So sometimes you can see something in the uterus, but it's not normal. What you're looking for a normal intrauterine pregnancy is a gestational sac or a fetal pole or a yolk sac or cardiac motion. So there are some differentiations between just seeing something in the uterus or not. So let's say you have an unruptured ectopic. You get your ultrasound back. There's something there in the tube. The reading is, probable ectopic. Again, a hemodynamically stable woman. You call your OBGYN consultant, and they recommend methotrexate. What is methotrexate? How long have we been using it? Who should get that? What's going on? So methotrexate is a chemotherapeutic agent that kills rapidly growing cells. It's been used since about 1985 in the medical management of these. It's actually also used for termination of pregnancies also in some cases. So it's used both those ways. Now, it affects the cells of the growing fetus, but it also affects your GI cells, your bone marrow cells, all those other cells that are also dividing, so it has side effects as well. Certainly the decision to give methotrexate or not should be a decision of your consultant, but you should know what the criteria are so that you don't start going down the wrong path in the wrong person. Certainly it has to be a hemodynamically stable woman, no evidence of any tubal rupture on your ultrasound or any significant hemorrhage, obviously. If you do have some free fluid finding in the pelvis on your ultrasound, that can be normal, so that doesn't always mean that there's some kind of hemorrhage. A small amount is normal, but certainly significant amounts are worrisome. The ultrasound needs to confirm the ectopic pregnancy, and there shouldn't be any fetal cardiac motion. It should be one of these that they're very suspicious of it, but it's not big enough to have cardiac motion. If it's that big, it's too big to respond to methotrexate. And the tubal diameter should be less than 3 to 4 centimeters if they give you a measurement. Patients with HCGs that are above 1,500 start to have higher rates of failure with methotrexate, certainly above 5,000. They usually don't respond. Those are getting more advanced and they're too big to really respond to methotrexate. They're gonna have a high failure rate. The dose of this drug is measured in milligrams per square meter, which is a body surface area measurement, which is how a lot of chemo agents are given. It's not a dosage that we're usually comfortable with. So it should be something that your consultant can recommend to you. If you need to calculate that out, there's ways you can do that on the internet. If you type this little dosage in, it'll give you a little calculator and help you make this calculation. It works somewhere between 70 to 85% of the time, and those are the same numbers for tubal patency rate. So it has a pretty high success rate, and usually the tube stays patent after treatment with methotrexate. The best results with this drug are seen when it's given in repeat doses and often in combination with other cytotoxic agents like leucovorin, which is actually folinic acid, and it can also serve as a rescue drug. It helps rescue the bone marrow cells from the effects of methotrexate. The risk for repeat ectopic with this drug is the same as with surgery, so it's about the same rates, the two treatments. And the most important part about using this drug is that you have to have obviously a willing patient who's reliable for follow-up, who will come back to the consultant to get their repeat betas to make sure the drug has worked. If you don't think that your patient's going to come back, they're not consenting to it, this is not going well, this shouldn't be a treatment that you choose. It has some rates of failure, and they have to come back, they have to follow up if they consent to this treatment. Now, the concept of persistent ectopic pregnancy, what does this mean? And this happens mostly with surgeries that are trying to preserve the tube, where some cells get left behind and then the ectopic starts growing again. And it's not very common, but it happens. 1 out of 10 with laparoscopy, 1 out of 20 with laparotomy type procedures. It happens about 10 days after the surgery. And so patients who have surgeries for ectopic need weekly betas to make sure that everything goes away, that the persistent ectopic situation doesn't happen. If it happens, you can treat those with methotrexate if the patients, again, choose to do so. There's a very rare concept called heterotopic pregnancy we should know about. It's more common in women who undergo infertility treatment, still not common in them, but more common in those patients, which is where you have an intrauterine pregnancy and an ectopic at the same time because of multiple eggs getting fertilized. So don't forget to ask patients about any kind of IVF treatment they've been getting it. It's a difficult diagnosis to make. It's often missed the first time around and results in tube rupture because the ultrasonographer sees an intrauterine pregnancy, oh, there it is, done, and doesn't look around. So if you have a patient who's undergoing infertility treatment, it's important to let the ultrasound tech know that we really have to scan carefully the whole thing. So it's remote, but it's possible. On the last page of the chapter, there's an algorithm, one of these famous algorithms that walks you through different scenarios and what you should do. This is just one of the recommended algorithms. This was published in American Family Physician, actually. But it's a pretty simple and easy to use algorithm, which is why it was chosen. And it uses the optimal strategy that the other paper, number 8, talked about. It starts with whether a patient's stable, then it goes on to the beta HCG. If the beta is above 1,500, again, the discriminatory zone. Ultrasounds of the most utility in this situation. If the level is low, below 1,500, they recommend a repeat beta HCG. If your ultrasound is non-diagnostic, again, a serial beta HCG is what's recommended in this algorithm. So just so that you know that you have that reference there for you to walk your way through and imagine some different scenarios, and it'll use a lot of the things that we've just talked about.
Isn't there a problem on the first branch, they're both stable, one should be unstable?
Oh, let me see. Yeah, you're right. On the right side, it should say hemodynamically unstable. Exactly. Immediate surgical consultation and treatment. Absolutely. So you're right. There's a misprint there. Good pickup. Early morning. You had your coffee. Good for you. You get a prize. So there you go.